don't recall any particular inspiration. Just as a child, I was always thinking about family practice, or especially thinking about orthopedics in those early years in my late childhood. And I thought I'd like to be an orthopedic surgeon. But then kind of drifted off to the military after high school, military, and then back to the University of Minnesota. And but that's a whole story in itself, how I got back to the university. University of Minnesota was my original medical school. Well, I had a standard medical school background. It was an excellent medical school. There was, I think, 120 in my class, of which there were 6 girls. 4 of them dropped out after the first year. Only 2 of them finished up the whole course. And I think one of them recently died, and the other one is still in Minneapolis. I finished medical school in 1944, I think. And that was right during the Korean War. And I'd only had less than a year of service during World War II, because the war was over by the time I was through. I didn't go in until January of 45, and it was over in May of 45. So I didn't have a year in the service during those early years. As a consequence, everybody that did not have a year of service in World War II was going to be called back to Korea. I did not fancy myself going to Korea, and I wanted to go back in the Navy where I was in World War II. I was in the Navy at that time, and Great Lakes Naval Training Station, as long as the war was on. I graduated from high school somewhat early, so I had a year of the University of Minnesota before I was drafted. So I went back, so I went into the service in 45, January 45, and got out shortly thereafter. After then, I came back to the university and finished my pre-med and went through medical school. And I know there was a fellow named Charles Bolsta, B-O-L-S-T-A, who was a old-time family practitioner in Graceville, Minnesota, that my mother knew well, who wrote me a very good reference letter to the university, and I think that's one of the reasons I got into medical school. Now this was, again, right after World War II, and I think I was about the youngest one in my class, because everybody else in my class were longtime vets, or most of them were, having 2, 3, 4, 5 years in the South Pacific and everything that you can possibly manage. 2 of my good friends flew airplanes off aircraft carriers during the Pacific War. So I had a lot of indoctrination into the wartime years, even though I wasn't actively in them. All my friends were at that time. So I finished medical school, and so I wanted to get back into a naval service because I knew I was going to have to go back in. So I volunteered for the U.S. Public Health Service. And I was stationed at Staten Island in New York, on Staten Island in New York, Marine Hospital. And I was married that fall, so I brought my wife to Staten Island. And we had a nice time on Staten Island. That was a good experience. But then, again, the Korean War was over, and I had planned to stay in the public health service for some time, but they were discharging everybody. They were really cutting service back then. So I came back home to Minnesota, got a job as a general practitioner up in Anoka, Minnesota, which is a little suburb outside of Minneapolis. Actually, it's what Lake Wobegon was patterned after. If you remember Garrison Keillor and Lake Wobegon, well, that was Anoka, Minnesota. Anoka, Minnesota, old Norwegian style. So I was there for a few months and decided that general practice was just not my thing. One of my patients, when I was in the public health service, was a sailor from Portugal. The public health service took all all the sailors, all the people on vessels. So it was Marine Hospital, anybody, and mostly Coast Guard. I remember I was assigned a few times to go over to Ellis Island, the Coast Guard call at night. But so I had one of my patients, this Portuguese seaman, but he had rheumatic fever and severe mitral valve disease. And he was virtually dying of untreated rheumatic fever. Of course, they didn't have much good treatment for it in those days anyway. So after I got back to Minneapolis and finally got a job in Anoka, Minnesota in family practice, just thinking about my patient with a bad valve, I was thinking that valves have been a part of pumps for 1,000 years. So why don't we make a valve for the heart? And so I made what I thought would be a prototype of plaster of Paris, carved a little valve out of plaster of Paris. Now, of course, it was non-functioning, it was strictly a model. After I decided I needed to get out of Anoka, out of family practice, not knowing quite where to go next, I went back to the University of Minnesota to talk to my old mentor over there, Dick Varco, who was one of my teachers when I was in medical school, but a very outstanding cardiac surgeon in his day. I remember I talked to his office secretary. She said, well, Dick could see me anytime I wanted. Just go up to the operating room and sit on the litter outside his operating theater, and he would see me. Well, in retrospect, that was kind of unusual because you just walk right in the main operating suite in your street clothes. Now, you didn't go in the operating room, but you'd go in the main corridors. So I sat on a litter outside of the main operating room and waited for Dick to finish up his case. And he came out and sat on the litter next to me, and I talked to him about my ideas of a heart valve and so on. He said, well, he had a good friend of his that had a heart research laboratory in the basement, and if I'd be interested, he would set me up to meet him. Now, that was C. Walt Lillehei. Now, Walt, of course, became a world-famous individual, and with his work there. So I went down to work in the laboratory. Now this suited me fine, laboratory medicine. I wasn't even thinking about surgery or anything else. The laboratory medicine appealed to me. So I worked in the laboratory medicine. I remember they had what was called controlled cross circulation at that time. That was where you'd connect a large dog and a pup together with various conduits going through a pump that would calibrate the flow on both venous and arterial, so it would be balanced flow. But of course, I was just new in the laboratory, and Herb Warden was the chief of the lab at that time. So somebody had to run the pump while he did the surgery on our experimental animal. So I ended up running the pump at that time. So I consider myself the first full-time perfusionist. That wasn't my goal, but that's how I ended up. But then they moved the cross circulation up to the main operating room and started to operate on children. Well, most of my training at Minnesota on heart surgery was with pediatrics because that's all you could operate on those days. With the controlled cross circulation, of course, you'd have an adult, usually a relative of the baby or the child, and plus the child. That didn't translate into adult surgery very well. And Walt Lillehei developed a worldwide acclaim for his work on congenital heart disease. He did the first total repair of many different types of congenital hearts in his operating suite there. Well, somebody had to run the pump. Now, you needed a heart-lung machine pump, but of course that came from the laboratory downstairs where the donor animal was the oxygenator, and of course had a mechanical pump. And I know when we were setting that up, they wanted to know what they could use for a pump. So Walt figured, well, he would liberate one from the physiology laboratory. So one day he just walked over there and picked up a pump and brought him over to our lab. What was very inventive to accomplish anything he wanted. Now, the morality of it didn't matter that much as long as the job got done. So we ended up with a pump there, and I ended up a main pump operator. One day after one of the heart cases, we were walking down the corridor, and Walt said, it's obvious we need to have a heart-lung machine. We just can't do this donor-patient routine, connecting a live normal patient up through a pump, because there is a hazard there. It's a general anesthetic. So Walt said if I wanted to work on a project, to work on a heart-lung machine would be a very worthwhile project for me. And if I wanted to do it. Now, I've always appreciated Walt in that aspect. He never told me I had to do it. He just said, here's an opportunity. Take it and run with it if you like. He said a friend of his made plastic hose for food, called the Mayon Company. He suggested, well, maybe I'd get some hose from him and I could figure out some use for it. So I got a coil of 1-inch diameter hose at that time. And several things Walt did say. If I was going to work on a heart-lung machine, I should not go to the literature. I should avoid bubble systems, because if I went to the literature, I might prejudice myself into the wrong way. He just wanted some new thoughts going into it. Well, that was part of the background. So then I didn't pay attention to him completely. I did have some knowledge of the literature, but I knew there was no mention in the literature of a hyperbaric system oxygenator, that is high pressure. So I decided, well, there's no history of a hyperbaric oxygenator, that's where I'll work. So I thought I'd build a hyperbaric system. So I had this long 6-foot length of hose. I figured I'd run blood at the top of the hose and have the hose built on an inclined plane and run it to the bottom. The lower third of the hose I'd use as a reservoir, and the upper 2/3 would be the oxygenator exposed to the hyperbaric oxygen. So I put in some ports and tied the ports to a D tank, which is a very large tank of oxygen, and had a pressure gauge on it so I could control the pressure. And I calculated that if 3 atmospheres of pressure would drive enough oxygen into the serum to totally accommodate the usual oxygen carried by the blood itself. So I figured, well, that'd be a good place to start. So I built this first hyperbaric system on this long inclined hose, and that seemed to work pretty well, except for the fact I didn't have the smarts at the time, or didn't think about it, to put it under high pressure like that, 3 atmospheres. I was a little concerned the thing might explode. I didn't know how strong that hose was going to be. But fortunately, it was more than strong enough to accommodate that kind of pressure. But in evacuating the blood out of my hyperbaric system, you had to reduce it to normal atmospheric pressure in order to return it to the recipient animal. Well, of course, what you'd end up, when you reduce to normal pressure, you would have all bubbles of oxygen coming out of it. Caisson's disease be a variation of the theme. When they developed the Lincoln tunnels, the tunnels under to New York City, they'd put these men deep underground, and they'd be under pressure there. Of course, they're under the weight of the water and everything else. But if they brought them to the surface too quickly, the oxygen or the air would bubble out of their blood into their system, and they'd kill them. So they had to decompress them very slowly. So that was Caisson's disease. caisson was the vault that they put these men in to put them underground. So I was building my own caisson's disease, and I figured, well, that isn't going to work. But then I also noticed that any bubbles that would come out of it would be stranded at the upper layers of the reservoir that I'd put at the bottom of the tube. And it seemed to be a very good debubbler. So I figured, well, I'll just make a bubbler system, personally create the bubbles, contrary to what Walt suggested, and that would clean the bubbles, the blood free of bubbles, and it'd be good to put back into the patient. I told Walt about it, and he said, well, I told him I had some dogs that I'd perfused with that system for a half hour at a time. He said, well, let's see them. So I remember taking those 10 dogs that I had out on leashes, out on the lawn in front of the hospital. And Walt came out and saw all 10 dogs, all very good shape, walking well. And he said, okay, you've proven the point. We'll set you up. So set us up, and we'll start operating on patients first thing. So that's how we moved from hyperbaric systems to bubble systems to dogs to people. 6 months later, I developed my heart-lung machine that worked very well. I was always kind of mechanically inclined. I could take anything and fix it, even as a child, practically. So when this opportunity came to think about a heart-lung machine, just in my general reading in medical school, I guess I had read enough about it, the history that had gone beyond it, and of course I wrote a history paper on it. Of course, the Germans did, there are a number of very good German papers on heart-lung machines back in the 20th century, 19th century. So I read all of those, and they came in all variety of different sorts, but none of them would work very well for people. So I was just using this background and my ingenuity, I guess you'd call it, and happened to stumble into the hyperbaric situation, which I mentioned, brought together. So that's nothing too dramatic about that. It took me about less than 6 months for my first experiments with my bubbler oxygenator till it was used clinically. So things came together fairly quickly. Of course, I did a lot of animal experimentation in that interval to prove the point. I've always appreciated Denton Cooley. At one time, there was a paper at the American Surgical Society of one surgeon presented a paper there using my system. He said, it's no good, it kills all the animals. Which I thought that was kind of offensive because I didn't have any trouble with that. But then Denton Cooley got up with a rebuttal and said, that may be true, but I've operated on 120 patients using that system and it works fine. So that put an end to that story, and it resurrected my reputation. So I've always had a lot of gratitude to Denton. I'd gone from a very good position as a staff at the University of Minnesota, but I accepted the position of chairman of surgery at Chicago Medical School. Now, I lasted there about 4 years, and it was obvious to me that it was not a place to be. But I was a consultant to the NIH on their artificial heart program, and I went to a meeting in Washington on the artificial heart program and mentioned to the director of that meeting that I would be very subject to a change of position. And he mentioned that to Doug Talbott, who worked at the Cox Heart Institute. So Doug called me on the phone and wanted to talk to me about it, and he flew up to Chicago. I remember we were sitting up on the 11th floor of the University Club overlooking Lake Michigan and talking to Doug about it. And so Doug suggested I might want to come down to Dayton and work. Just saying there was a new hospital there and be a good opportunity. And he was developing the Cox Heart Institute at that time. And he had He was a very visionary fellow. He had great ideas. Unfortunately, he got sick and never followed through on them, but that's what brought me to Dayton. Paul Kedzie was the fellow that worked at Cox. It was Doug's right-hand man. So it was Paul Kedzie that mentioned it to Doug, who was also attending at a later meeting at the NIH. So Paul Kedzie and Doug got me to Dayton and looked over the situation. They had a good research lab over at Cox, good animal attendant research activity. So it looked very appealing to me at the time. It was a research opportunity. And of course, Bob Taylor had a private thoracic surgery practice, and so it gave me an opportunity for a clinical outlet. Now, while I was at Minnesota, I'd worked in the laboratory about 2 years, and all of a sudden in the fall, new assignments came out, and I was assigned to a clinical service. I never applied for it or anything else. And I think I'm probably the only resident that ever graduated from a residency program and never applied for a residency. I never did apply for it. I was just assigned. And so I went through and got my thoracic surgery training at Minnesota, then came down to Dayton. I knew the heart surgery programs around the country. That was one of the advantages I had working in the research lab at the University of Minnesota and developing the cross-circulation experiments. We had visitors from all over the world, from Russia and France, England, South America. So I got acquainted with a great number of people, including Denton Cooley and Mike DeBakey, and got to know them, got quite friendly with them. And moving to Dayton, I looked at the competition in the local area. And around Dayton, there was no competition. Columbus had a stumbling program. Indianapolis wasn't really off the ground. Cincinnati, they were fumbling around. So I figured, well, it was a wide open area for cardiac surgery. There's very little competition from those areas, so I figured it was a good place to start a program. The only nearest competitor in cardiac surgery was at the Cleveland Clinic, and of course that was Don Effler up there, and he developed an excellent program up there. And then working with Bob Taylor, who was in private practice there with Charles O'Brien, they helped set me up doing thoracic surgery in Dayton. Of course, we wanted a heart program, which I had in mind. And so I had all of the various accoutrements necessary to develop a heart program. I had it either in mind or had a list of all the instrumentation necessary, all the various drapes that you needed. There were specially cut drapes to accommodate that type of surgery. But then that's where Ellen Strobel comes in. She was, I don't know what her job was, but she was assigned to take care of all my needs for the heart surgery program. So probably I owe it to Ellen as much as anybody about getting the heart program started and underway. So my first heart patient in Dayton was a woman from Miami Valley Hospital that had a pulmonary embolism. But unfortunately, in those days, diagnoses were pretty sketchy at best. So I operated on her, and she unfortunately died, and she did not have a fat embolism. Well, she did have a fat embolism, but not a thrombus embolism. So the fat embolism, she'd been into some kind of accident and distributed a lot of little bundles, little droplets of fat throughout her lungs, and of course, there's nothing you could do for that. So the point being that the poor lady died under my hands. My first patient at Kettering was a woman that died. Wrong diagnosis. Should never have been operated on. But I was told she had a pulmonary embolism, in other words, blood clots to her lungs, and that was not the case. So that was a big problem in those days to differentiate pulmonary embolism, fat embolism from thrombotic embolism. But anyway, that's the way it turned out. Now that's where Carolyn Weimer came in, because she was assigned to scrub on that first case with me. She will tell you. She was scared to death. But I thought she did an excellent job. She was a wonderful charger. She was a great nurse. I always thought She was a great nurse and knew the procedures well enough. I never had to ask for an instrument. I just hold up my hand. She'd hand me what I needed, whether I asked for it or not. So Carolyn and Ellen Strobel, those two ladies, helped to get the program underway at Kettering. That's when Ben Schuster started to work over there. Now, Ben, of course, was an outstanding cardiologist, and he had a good lineup of patients. Now, of course, before you operate, you have to have patients, and he provided a good source of patients for me. But interesting, when he first started to work over at Kettering, they had no catheterization laboratory for diagnosis. So what he did was take the patients to the X-ray department, and we use the standard X-ray machines, fluoroscope, for his catheterizations, which I don't know how in the heck he was able to do it, but apparently he was able to get enough definition to get basic catheterizations work. Well, this went on for a few months, and finally Virginia Kettering, and I think Gene also. Gene was pretty sick at that time, and he was not doing well at all. But Virginia got into the act, and so she saw what was going on, and I don't know, maybe Doug Talbott talked to her also, or I don't know who all talked to her, but she very kindly came across and built the first catheterization laboratory, and of course supported the program ever since. Now, a little addendum to that, while she supported the program, she had her own aortic valve replaced in that operating suite that she put together and facilitated, maybe 20 years after the fact. So Virginia got her returns out of the lab and out of the efforts there. Prior to Mrs. Kettering's heart valve surgery, she invited a few people, a lawyer and a cardiologist and a few other people, her advisors over to her apartment over in right up the hill here to talk over heart surgery. And we convinced her that she would have just as good a heart surgery here as she could in Houston, Texas, or any place else. Well, I think the end facts proved the case. He survived the procedure well, had a good recovery. And incidentally, I had brought my mother from a little western town in western Minnesota who was having severe angina. Brought her down here, and she was operated a couple of weeks before Mrs. Kettering, and she was 91 at the time. So we were able to take on some elderly people. I think I wrote a paper once of, what did I have? 30 or 40 patients that I'd had over the age of 70, I guess it was. There was not a single death. They all survived well. They all improved. So I thought that kind of put an end to this thought that they're too old to operate on. They're never too old to operate on. It's physically are they able to do it. So you had to look at their physiology and not their age to see if they would be a good candidate. Well, there are some people in their 50s you wouldn't touch with a 10-foot pole because they're in such bad shape, lungs are shot. And that was one thing that I insisted that my patients not smoke before surgery. In fact, I remember canceling a couple of cases that were scheduled to go ahead because they were smoking up to the night before surgery, and I said, no way. So I canceled them and put them off for a couple of weeks until their lungs could clear a little bit. So that smoking was really bad news for heart problems. Well, I think it evolves around support from Virginia Kettering. Well, she built the first cath lab when, as I mentioned, Ben was catheterizing patients in the X-ray department with a fluoroscope. Now that is not a viable long-term solution. So, and of course, I think the Ketterings built our first specifically designed operating suite for heart surgery. So they had their hand in everything that helped in the physical development of the program. But by then, I got so busy in the operating room at Kettering, I just kind of had my research at Cox kind of drifted into the winds. I just didn't have time to do it anymore. Although I didn't do oxygenator work at Cox as much as I did other work, transplantation and other things over at Cox. Well, I provided the operating room personnel, the perfusionist, the fellow to run the heart-lung machine. I think I had some other personnel that I brought on board too, to help the program going. So we established a whole procedure to get the backup chemistry laboratory. And of course, Carolyn really came right into the act and was able to assemble all the instruments and get the operating room set up for every case that came along. But Ben Schuster came along with Mrs. Kettering's help and developed a very good flow of patient material, and, for which I had eternal gratitude. Ben really worked hard. He was really a dogged. He put in his 12-hour days regularly. So it was working with Ben, we were able to develop a flow of patients, and it was just routine surgery from that point on. I started the surgery residency program maybe 10 years later. And we had some of the surgical residents scrubbed in my service periodically. Tom Percy was one, and David Small. They both became very well-established surgeons later on. So they're part of my pride and joy that I produced from the surgery training program there. But they were not part of the long-term heart surgery program at all. They were just participated and learned some of the basics of thoracic surgery. And I've often thought about it, even when I was doing pediatrics to a great deal. I was very blessed to be in heart surgery, because here you're taking people with a very limited life expectancy, children that are ultimately going to die within a couple of years at most. But you're able to give them a normal lifespan. So a child who would die at the age of 3 years old, he could live to be 70 or something. So I think that's one thing I've often remembered, the many years you could give people. Well, gathering of great people like Ellen Strobel and Carolyn Weimer. There was also a chief of coronary care unit, Pat O'Reilly. He was apparently hired as one of the first nurses to come to Kettering when they opened up. And they needed somebody to direct the coronary care unit, so they asked Pat to do it, and she did a magnificent job. She was a great delight. Now, I never had any patients in the coronary care unit because that wasn't my thing, but I always find excuses to go up there just to talk to Pat. It was a great addition. As you speak about how does the heart program going, it's people, dedicated people. Well, I think they'd be very pleased with it. I think we've developed a very good reputation. So at a cocktail party at the Ben Schuster's one night, and I didn't know how to get in touch with the university to review with them what we needed to do for medical school. But then I ran into the Dr. Anand, who was a chairman of the Department of Economics at Wright State. He was at that party also. And I talked to him about what we needed to do for a medical school. So he said, well, he'd take the ball and run with it. So I got a call a few days later from the president of the medical school, president of the university, to come and talk to him about it, which I did. So I remember going out to the university and talking to the president. And he liked the idea. He said, well, he would run with it. And he got Bob Conley, who was the chairman of engineering, to help put my proposal. I spent about 3 years drawing that proposal together after I came to Dayton. And so they had to put it in a university format. Of course, my self-typewritten proposal, and I thought it was pretty good myself. But they had to recast it, of course, and I could understand that. I started to use PAs, physician's assistants, surgical assistants, and they did very well and served very well. Now for my work, I did not need another surgeon to assist me. I knew what I was doing. I didn't need another surgeon there. You just needed somebody to help hold tissue back. And so I brought some PAs on board. Then the state in their wisdom decided they had to license PAs. So there was a brouhaha about licensing PAs, that you couldn't function in the hospital unless you were licensed, except to the point they didn't establish a way to get a license. Now I took that as somewhat offensive, so I sued the Attorney General of the state of Ohio. And they finally backed off and agreed to get a program going underway, and they got it finally licensed. And I finally brought people on board that had passed their licensure.
I started at the hospital in 1964 in October, and 2 years later I was asked to participate in the opening of our heart surgery program. And so I was asked to be the scrub nurse, and Ellen Strobel was asked to be the circulating nurse. And then we had Bob Pilarski came to be the perfusionist,
Yeah.
and you as the surgeon. And so we had a skeleton crew, and you know, it just progressed from there. But our first patient that came, as we both probably very well remember, came over from Miami Valley Hospital.
And she died.
And she did. It was a pulmonary embolus, and it was...
But it was a fat embolism and not a thrombotic aneurysm. In other words, a misdiagnosis.
Mm-hmm. And that was one of the scariest times of my life, I think, because we really hadn't had a chance to really sit down and talk about instruments, and that's what my role was, to pass instruments, and it was it was a harrowing day. I'll just have to say that, but we did our best. But it was I would just have to say it was stressful for everybody, and
Not me.
well, I can tell you it was for me. And but you know what? I just we all throughout the program, throughout all our careers, it was a matter of teamwork. It was always about teamwork. It couldn't have happened without everybody working together.
That, because I'd been doing it at that time, I'd already been doing it for 10 years. But in Minneapolis and Chicago, so I didn't think I was an amateur anymore. Was I?
I was. I came from a 3-year diploma program in Western Pennsylvania, and the biggest surgery that I ever saw was a twice a year, maybe a thoracotomy. And when I was asked to participate in this program, it not only was a real honor, but it was frightening for me, coming out of a really small 3-year program, and but I was taught by the best.
Well, you concealed your fright very well. You looked very calm and collected through the whole case.
Well, when I was driving down here today, I took the same route that I used to take when they would call me all hours of the day and night to come in for emergencies. And I always just said a brief prayer for guidance, for calm, because that spilled over onto the people in the room. And so I felt if I could be just grounded and calm, it was going to help the patient and everybody in the room.
Well, it helped me.
And we were very isolated. we, for the most part, never went to the dining room because we didn't have time. And there were many, many times, and I'm sure you remember, I mean, we didn't get breaks, we didn't get lunch, and if there was a really critical procedure going on, you couldn't just go get lunch. It just wasn't fair. It wasn't fair to the surgeon, it wasn't fair to the patient. And so there were a lot of times that we stood there for many, many hours, and thus sore backs, sore feet, and bad necks. We had a very successful cardiac surgery program. And again, it was the teamwork. People who were so dedicated to what they did.
Carolyn was wonderful in that you never had to ask her for the instruments you need. She just handed you what you needed. And if you asked for the wrong tool, she'd still give you the right one. Right?
Well, oh, maybe. No, after we worked together for long enough, you learned just pretty much what you needed, and I'm really happy that I was able to participate in that.
Never occurred to me we were evolving. We just did the work that came our way.
We did, and there was a quite a period of time that really we were on call always, because there was a circulating nurse. The circulating nurse at that time, pretty much, takes care of a lot of what goes on in the room. The scrub nurse stands right beside the surgeon and hands instruments. When our cases were finished, we were responsible for those instruments, and we didn't have multiple sets of instruments like they do now. We were responsible for cleaning all the instruments, taking them out of the room, cleaning them, and getting them put back in packs and sterilized for another potential case. And so we were busy. We were really busy. And I will have to say, Dr. DeWall, and we all remember this so well, he always helped us clean the room. I never saw any other surgeon do that, but he always helped us, and I think part of it was a little bit of before he went out to talk to the family, just a little stress reliever maybe, and always thanked everybody in the room. This was something that he always did, was thank everybody by name. It wasn't just walk out the door and say thanks. It was go around the cleaning people, the aides, everybody. Thank them. I had never seen that before, and it was special. It made us feel really good to be part of that team.
Well, it's really, I guess you might say, selfish in my part that I'd help clean up the rooms, because it helped move you on to the next case more quickly. And that was, time was of the essence. I was going to spend many hours there, and I wanted to limit it as much as possible. So if you get the old stuff out of the room and get the new stuff in quickly, of course that pushed you in getting things washed up and cleaned up.
Yeah. And I was thinking the other day, asepto syringes that are tossed, we had to clean those and sterilize those also. So it was a time and period of not a lot of disposables, and now everything is disposable. But even all the blood work that was done during cases, the circulating nurse was running into the little mini lab that we had right outside the room that we used the only room we had when we started. We had one heart room, room 4, old room 4.
Yeah.
And there was a little mini lab, and the circulating nurse would run out there with tubes of blood and run blood gases. That was part of what they did. and that was the room where the pump was set up. And then as we expanded, then, and also there was a cast room between room 4 and 5. So they got rid of the cast room, incorporated that into room 5. So at that point, we had 2 rooms that could be used for heart procedures. And then there were several other smaller rooms that were equipped for, more power, more gases and so on that we needed that could be used if we had both 4 and 5 running at the same time. So there was, I thought so many times, that surgery schedule never was the same at 2 o'clock in the afternoon as it started off in the morning. I don't remember ever a schedule going as scheduled, because we never knew what was going to come through the door. Well, it probably did for the people working in the office, trying to, figure out where we were going to
fit people here and there.
Yep. I really would just like to say that being part of that team, being asked to be part of the team, was totally instrumental in me developing a lot more self-confidence and being able to function in the capacity that I did. And I feel that I owe it all to being asked and being part of the program and working with you. It really was, it was quite a special thing. We, as RNs, had to collect a certain number of continuing education units to keep our RN. We were responsible for this. Well, we all had families. It got costly. But Dr. DeWall's office provided us with the means of attending a meeting once a year that the office paid for. And I can never say how grateful we all were for that, because it was just a really special thing to be able to go to a really good meeting and collect those CEUs to keep up our RN.
Did you actually get to the meetings?
Oh, yes. Yeah, you did. A lot of it was AORN, which is Association of Operating Room Nurses, and lots of meetings to go to within that framework of time, and it was good. We all just, it did. Some of the days were very long. We all would stand on a bath blanket just to absorb some of the hardness out of the floors. And, there were a lot of really long days.
But you had your own elevated throne. Your table was higher than I was, and didn't you stand on a stool of some sort to get to your table?
Sometimes I would, not always, but because if you did stand up a little bit, you could at least look down to see really because it was
to
really
see what
critical
I needed.
to really see what was going on and to anticipate the next step. I would have to say I was really in awe of the whole, just the building and the people, because I like I said, I just came from a small program, and I actually had been accepted to work at another place, and somebody there said to me quietly, "Why don't you go check out this new hospital?" And I went, I called for an interview, and I was interviewed by Georgia Hart, who was our first supervisor, and started the next day. I started the next day. And I've never certainly regretted, ever, for a second. I would say the thing that impressed me was the healthy living, the standards. Of course, not being a smoker, that wasn't an issue, but I was that pleased me. I have had no regrets, and I have appreciated learning more about the Adventist healthcare system, and I know it's all over the world. So something's being done right.
Well, I've got one thing that impressed me was the cleanliness of the hospital. Even the corridors and the stairwells were so they were clean. You go up and down those stairwells, put your hand on the railing, it ended up clean. When I was in Chicago, boy, it was, you end up with your hand would be black if you'd walk down the stairs. I don't think they cleaned their stairwell once every 5 years. But to walk into a place from where I was, glad to get out of there, and to see such an immaculately clean place wherever you turned, it was clean. And that impressed me.
I think it's really, really important to remember that people who have, that people who are undergoing surgery or who are critically ill have families that need to be dealt with because they're scared. And to have a friendly face, a friendly nurse, either in the surgery unit, come out and talk to them, or on the units. I think that's really, really important, and I know that from firsthand experience.
Well, they just select good people, and then you put them in a spot and say, "This is your job. Now do it." Isn't that about it?
Pretty much so. Yeah, I mean, early on, I don't know why I was chosen. I don't. I certainly know why Ellen was chosen, but when they asked me to be the scrub nurse, it was an honor, but it was really terrifying, and then we trained other people as time went on, and our schedule got larger and larger. Other people had to be involved, and so, they were, for the most part, were hand chosen as people that would be really interested in serving on this team. And we after a period of time had physician's assistants, and they were, for the most part, very, very helpful. And the perfusionists, we all worked together. A lot of our anesthesiologists, before they became anesthesiologists, a number of them had been scrub techs, or they had worked as scrub techs. They were always willing to get supplies. If the room was really busy, anesthesia people they'd pitch in. I've seen anesthesiologists prepping the patient with a solution that we use, betadine. Everybody worked together. It was a good team. There were a lot of good teams. People knew what they had to do, when they had to do it, and I know things have changed somewhat. I've been retired for a while now, but I used to get called in the middle of the night, and it was, I would hear, "This is what's going on. Don't say no, just come." Well, you just
That
didn't
was pretty
say.
cool.
Well, but you knew that there was somebody very ill, and you just didn't say. You couldn't say no. Could be your parent or a spouse. So we went. We started, now of course, when we were doing heart surgery, we had to be there very, very early because we had no night crew. So we had to come in, set up the room, open up all the packages. So we came in around 5:30. But when we weren't doing heart surgery, we started every day with prayer in our classroom. The whole staff, when we started the schedule, before we started our schedule, we always had prayer. I don't know whether they do it now or not, but we did. And I can tell you, prayer was, and I mentioned that, I always just handed it over when I knew that there was something critical going on. I mean, I think prayer was an important part of my life always. And I know it has been yours too. And I think it's all certainly an individual thing, how you feel about it. And I certainly think anybody can pray anytime, anywhere, without, you can just pray quietly to yourself.
Right. I was chastised a couple of times, not necessarily in a prayer move, but every now and then I would extol the help of the Almighty, and if I got into a difficult situation. You remember that?
Mm-hmm.
It wasn't disrespectful, I just needed help.
As we often did. I would have to say that just being really part of the heart team early on, when things were we just were started with our very first case, it really helped me grow professionally. And I'll always be grateful for that, because it is carried through into my private life, being more self-assured. People often say to me, well, you're full of self-assurance. Well, there was a point in my life that I absolutely was not. And so I'm grateful for that. I am. I've learned to branch out and be comfortable doing things. I've always been an Indian and not a chief, but I'm still working on that goal. Without the teamwork, it couldn't have worked. Everybody worked together. It's what it had to be.
Everybody did their job.
Mm-hmm.
But without everybody doing their job, it wouldn't have gone. You needed everybody pitching in. Well, I only represented the backup team, without which there would be no surgery.
Well, it's been my privilege for a number of years to work with this special, special man. And I appreciate being included today. This has been quite lovely.